you today is some of my early experiences in trying to incorporate co-design methods in the process of trying to design patient safety solutions for older people in hospital. And through that, I hope to share with you why I think co-design and participatory methods in general actually might be some of the most powerful tools we have to try and fix the broken healthcare system and to advance progress in patient safety. And no more so than in my area of research, which is falls prevention. It's a problem where we see over 1 million falls being reported every year in US hospitals alone. It causes a lot of pain and suffering. And it's one that we don't actually have a lot of good solutions for. In fact, we don't actually have, at this point in time, the best evidence available. We don't have a suite of effective interventions to prevent falls in hospital. But I'm optimistic that change is possible, and I think change will come by shifting our focus from having our blinkers on and trying to just treat the risk factors for falls, and rather looking at how we might be able to optimize the environment of care so we can meet patients at their current functional status, where they are in their, where they presently are in their recovery journey, and we can do that by optimizing the environment. And one of the things that I was particularly drawn to early on in my PhD was looking at this issue of lighting in hospital. Because we know a lot of our older patients who come into hospital and have falls also come with visual problems. And the likelihood of falling, if you have visual problems in a dimly lit environment, does go up. But since we knew so little about this problem, in hospital especially, we didn't really know what lighting hazards were present. In 2011, a group of us decided to go and actually get some observational data on what actually occurs in hospital, how these environments are set up, what light levels do, and things like that. And so we audited 22 wards in my health service, and we tried to identify some hazards for, try to look at what the physical environment was like, and what hazards were present in terms of sleep quality, in terms of falls, in terms of independence. And what we found was there was a range of things that came up, and when we tried to organize them thematically, it was quite clear that a number of these issues could be resolved through optimal design of that environment. And so I was lucky by that stage to have a very great group of diverse researchers with diverse skill sets, and we decided to put together a design concept to address some of the functional issues we had identified. And I won't tell you all the details about it, but it was based on an LED strip lighting solution. And the idea was to provide point of interest lighting where it was needed and not where it wasn't. And it had multiple components, and we envisioned that it would be controlled through motion sensitive triggers. And at this stage, and we sort of got quite granular with it. We even went down to the decisions around the kinds of track options we would use, the diffusers we would use, to make sure we got that illumination profile absolutely right. But at this stage, we did something quite unnatural as far as safety research goes. We decided not to go to a pilot trial. We decided instead to go to our users and see if including them in our conversation could actually improve the solution. And how we did that was we fabricated a whole bunch of mobile testing units, and I'd go into hospital wards and I would install them in actual patient rooms with patients in them for a number of hours every night. And at the end of that period of immersion, we would ask patients and clinicians what they thought about the solution and get them to hands-on co-design with us and change the physical characteristics of what we had put out for them. And we did this across 12 wards in 3 healthcare facilities. And in every 3 trials, we would come back as a group, review the design features, keep the ones that were, had been modified if we found they were in line with our design goals, and then re-inject that into another iterative cycle of redesign and evaluation. And so I'll give you some more grainy photos from my iPhone 2 from the trial. And I guess if you wanted to have some specifications as to what we did, you can find that in the paper that's been published in 2015. But what I really want to impress upon you is that the solution that we subjected to our randomized control trial was actually the one that came up through the user testing. And I'll leave you with 3 points of reflection. If you'd used a survey-based approach as opposed to actually opening up a creative space for users to get involved in the discussion, would we have got the same level of value through it? And if clinicians, frontline clinicians and patients are actually giving us the best solutions for patient safety, who are the actual experts in the story? And so with that, I'll ask, what does this mean for you in your practice going forward? And conclude with that. Thank you and happy co-design.